This conference will now be recorded. This conference will now be recorded.
Hello? Hello? Sound ekunda sound.
Good morning, sir.
Sound anta. Sound anta. Full unda. Sound full ga unda. Hello?
Good morning, sir.
Hello? Hello, students. Are you hearing me?
Yes, sir. Yes, sir.
Hello? Are you able to
Hello,
hear?
sir. Yes, sir.
Huh? Are you able to hear?
Yes, sir.
చాలా లోగా ఉంది వాళ్ళ రెస్పాన్స్. హలో వాళ్ళు అంటే వాళ్ళు అనేది నాకు కనిపించలేదు. నాది బాగా వినిపిస్తుందో తెలియదు. ఎస్ అంటున్నారు. వాళ్ళు వాళ్ళ వాయిస్ లోగా ఉంది. హలో హలో వాళ్ళు వినిపిస్తాను బాగా.
హలో హలో
సార్ ఓకే. Good morning, everybody. I'm continuing yesterday's class, diabetes mellitus.
సార్ క్లిక్ చేస్తే
ఇది ఇదే
ఫస్ట్ స్టార్టింగ్ అప్పుడు ఒకసారి క్లిక్ చేసి స్టార్ట్ చేయండి
స్టార్ట్. ఇది ఒకసారి టచ్ చేయాలి.
ఇప్పుడు అవసరం లేదు సార్. ఫస్ట్ స్టార్ట్ అవసరం.
ఫస్ట్ అలాగే
బయట ఉంటుంది.
తలుపు దగ్గర. Yesterday I discussed about the classification of diabetes. Primary diabetes is most important, most common. Diabetes means primary diabetes, and there are two types, type 1 and type 2. It is a metabolic disorder affecting carbohydrates, proteins and fats. It is due to the common feature for all diabetes cases is hyperglycemia. So that will hyperglycemia is due to absolute or relative deficiency of insulin, inadequate insulin action or insulin resistance. Whatever may be the cause, the clinical features are in both cases are almost same. Patient may be asymptomatic, particularly in case of type 2 diabetes in early stages, but once established, the patient will develop classical symptoms of polydipsia, polyuria, polyphagia, lethargy, fatigue, and in late cases patient may develop symptoms related to complications. So the classical triad is polydipsia, polyuria and polyphagia. Polydipsia means increase in thirst. Polyuria, increase in volume of urine. Polyphagia, increase in appetite. And lethargy, lack of energy and enthusiasm, fatigue. These are the classical features of diabetes mellitus. So we will discuss the basis for these clinical features. Polydipsia, that is increased thirst, is because of elevated glucose levels, blood glucose levels. The glucose appears in urine when the renal threshold is reached, that is 180 milligrams per deciliter in the blood. When the hyperglycemia crosses this renal threshold 180 milligrams per deciliter, glucose appears in urine. So water is also osmotically attracted from the body cells in the blood and results in intracellular dehydration and hypothalamic stimulation of thirst. So polydipsia, increased thirst, is because of high glucose levels in the blood. That is that raises the osmolarity of the blood. So it draws water from the cells. So intracellular dehydration occurs. It draws water from the interstitial tissues and it draws from the cells. So cellular dehydration occurs and it will stimulate hypothalamic centers of thirst. That is the cause for polydipsia, increased thirst. And next, hyperglycemia is associated with glycosuria, presence of glucose in the urine, glycosuria. So just like in the blood, hyperglycemia draws water from the cells. Urinary solute, increase in solute, that is glucose, also draws more of water due to osmotic effect. So osmotic reason effect occurs, and glycosuria associated with large volumes of water excretion in the urine. So glucose is filtered by glomeruli of the kidney. If it exceeds the amount that can be reabsorbed by the renal tubules, that is renal threshold, glycosuria occurs, and this is accompanied by large amounts of water lost in the urine. This is also because of osmotic reasons, and that is polyuria. Polyphagia is increased appetite, depletion of cellular stores of carbohydrates, fats and proteins, results in cellular starvation and corresponding increase in hunger. Insulin is anabolic hormone. It causes synthesis of carbohydrates, that is glycogen, fats and proteins. So in the absence of insulin, when the glucose is not available as energy source, the other nutrients like fats and proteins are broken down to give energy, and that leads to emaciation and starvation. So there is correspondingly increase in hunger. Weight loss occurs because of fluid loss, dehydration, and due to osmotic diuresis, and also loss of body tissues because carbohydrate, proteins and fats are broken down. That will lead to weight loss, and proteins and fats are utilized for energy purpose in the place of glucose. So that leads to weight loss. So in spite of increased hunger and eating, the patient develops weight loss. This is a paradoxical situation. In this situation, we should always suspect diabetes mellitus, increased hunger and weight loss and weakness. So that is a paradoxical situation where we should suspect diabetes mellitus. And fatigue, metabolic changes result in poor use of food products, contributes to lethargy and fatigue. Sleep loss from severe nocturia also contributes to fatigue. Now, clinical features of diabetes mellitus. I will explain this again here in graphically. The insulin deficiency, how it leads to polyuria, polyphagia, and polydipsia. So polyuria is because of cellular decreased cellular glucose uptake. That is glucose utilization is decreased by the muscles. So there is hyperglycemia. Hyperglycemia leads to glycosuria. So along with glucose, water is also lost in excess. That leads to polyuria. And hyperglycemia, that condition, in that condition, the body fluids draw for osmotic reasons. Intracellular water is drawn, and that stimulates osmoreceptors in the brain, and that will lead to intense thirst, that is polydipsia. And in the absence of glucose utilization, fat deposits in the adipose tissue and proteins are degraded. There is lipolysis and proteolysis in the muscles. So this will lead to negative nitrogen balance, weight loss, and that stimulates appetite, that is polyphagia. So these are the pathophysiological causes of the clinical symptoms. So once you suspect clinically, it requires confirmation of diabetes mellitus. So urine glucose levels are screening tests that will detect the presence of glucose in the urine, but it appears when urinary blood renal threshold for glucose, that is 180 milligrams per deciliter, is exceeded. But urinary test, glycosuria, must always be confirmed by examination of blood. So plasma glucose level or value is defining. Plasma glucose value is defining for diagnosis of diabetes mellitus. This is confirmative test. Urine test is screening test. It can be done on many patients who are suspected of having diabetes, but confirmation must always be done by examination of plasma glucose levels. So you should know what are the normal levels, what are the levels in impaired glucose tolerance, and what are the levels which are confirming the diagnosis of diabetes mellitus. You should know the fasting value, and overnight fasting for at least 8 hours. The morning sample after overnight fasting should be below 100 milligrams per deciliter. This is the normal fasting blood glucose value. Normally is about 70 to 100 milligrams per deciliter. 70 to 100 milligrams in fasting glucose blood sugar level, normal. So if it is between 100 to 125 milligrams per deciliter, then you should call it a impaired fasting glucose level. Impaired fasting glucose, that is impaired glucose tolerance. So this condition after within a few years may lead to frank development of diabetes mellitus. So in that condition, the blood glucose is 126 milligrams per deciliter or more. So these are the standards given by American Diabetic Association. This is fasting blood glucose levels. After doing this, if the patient is diabetic, all right, you need not go for 2-hour glucose oral glucose test, that you need not go for that. Only in case of impaired glucose tolerance, impaired fasting glucose levels 100 to 125 milligrams, then you have to go for the next test, that is 2 hours. You should give patient 75 grams of oral glucose dissolved in a tumbler of water, and after 2 hours you should take again the blood glucose value. If it is less than 140 milligrams, then it is a normal condition, and still it is impaired glucose tolerance if it is 140 to 200 milligrams. And if the value after 2 hours of 75 grams oral glucose load, if the value is more than 200 milligrams per deciliter, the diagnosis of diabetes mellitus is confirmed. So either the first, the second, or the third are required for the diagnosis of diabetes mellitus. In the third case, a random value above 200 milligrams in a symptomatic patient, it should be diabetes mellitus. So in a symptomatic patient with polyuria, polydipsia, polyphagia, lethargy, fatigue, if you do a random sugar test, blood sugar test, if it is more than 200 milligrams, then you can make a diagnosis of diabetes mellitus. And the another important investigation in case of diabetes mellitus is hemoglobin A1C. This is glycated hemoglobin value. Glucose is non-enzymatically complexed with the globin part of the hemoglobin, and this value is in the range of 4 to 5.56% of hemoglobin. That is normal. If it is between 5.7% to 6.4%, it indicates increased risk for diabetes mellitus, and values above 6.5% confirms the diagnosis of diabetes. So this is not only of a diagnostic value, but also is important in monitoring the confirmed cases of diabetes. In management of diabetes, this test is very important, because blood glucose levels are fluctuating. It depends upon the patient's condition of stress, infections, diet in the preceding 3 to 5 days. But here the hemoglobin A1C, because it is non-enzymatically complexed with hemoglobin in the red cell, it gives a value of value over a period of 3 months, 120 days, because the red cells are surviving for a period of 120 days. So it gives an impression of glycemic control in the preceding 120 days or 3 months. So because of this long-term assessment, this test is of value in managing the condition of diabetes mellitus. So we go to the complications of diabetes mellitus. Apart from symptoms, which are manifestations of disease, complications occur in diabetes mellitus. That is why we are concerned with this disease, and these complications are associated with increased morbidity and mortality. Acute metabolic, the complications can be divided into acute metabolic complications and late systemic complications. Acute metabolic complications, when the hyperglycemia is severe, these complications may occur, and these include ketoacidosis, non-ketotic hyperosmolar coma, and hypoglycemia. Ketoacidosis is important complication most commonly occurring in type 1 diabetes, insulin dependent diabetes mellitus. Non-ketotic hyperosmolar coma is a complication occurring most commonly in type 2 diabetes. And apart from hypercalcemia and associated complications, patients with type 1 diabetes who are dependent on insulin may sometimes develop hypoglycemic episodes. Hypoglycemia. This is because there may be an overdose of insulin, over treatment, or after taking insulin they may miss the meal. Then this will lead to hypoglycemia. Hypoglycemia is difficult to tolerate and could be much more damaging immediately than hyperglycemia. So it produces confusion and even coma. So, but this condition must be recognized in all cases of diabetes. And late system complications are diabetic vasculopathy. Diabetes causes changes in the blood vessels. Diabetic vasculopathy, it changes in the functions, structure and functions of kidneys. So renal complications are described as diabetic nephropathy and diabetic neuropathy. Diabetes affects the functions of the central nervous system and peripheral nervous system, both motor neurons and sensory neurons. So it is diabetic neuropathy and diabetic retinopathy, important complication occurring in the eye, retina. So retinal changes may lead to adult onset type of blindness, particularly blindness. So these are the apart from these types, patients with diabetes mellitus are prone to develop various types of infections because of impaired immunological response to infections. So we will discuss in detail these complications. So first discuss about acute metabolic complications. Diabetic ketoacidosis is a complication most commonly occurring in type 1 diabetes. It is precipitated by inadequate insulin therapy, severe hyperglycemia, and intercurrent infection. It is precipitated by emotional stress and excessive alcohol intake. And clinically, patient develops anorexia, nausea, vomiting, deep and fast breathing. That is called Kussmaul's breathing, and mental confusion and coma. So once you diagnose this condition, diabetic ketoacidosis, diabetic ketoacidotic coma, so you give intravenous fluids and also insulin. So most patients will recover from ketoacidotic coma. Another type of complication, hyperosmolar hyperglycemic non-ketotic coma, occurs in type 2 diabetes, and blood sugar is extremely high and plasma osmolality is high. So the patient is dehydrated and blood viscosity increases. This leads to thrombotic tendency and bleeding complications, and this is a frequently fatal condition. So mortality rate is high in case of this complication. Again, the institution of insulin and fluids, maintenance of fluids, is the treatment for this type of coma. And hypoglycemia develops in patients of type 1 diabetes who are insulin dependent, and excessive insulin administration of insulin, or missing a meal after taking an insulin, and or due to stress, hypoglycemia may develop. This may also cause coma. So you have to distinguish the about two types of coma from hypoglycemic coma by proper history and laboratory testing. So we should know the pathogenesis of diabetic ketoacidosis. In the absence of insulin, it occurs most commonly in type 1 diabetes, which is insulin dependent diabetes mellitus. So insulin must be given. So in the absence of insulin, the action of other hormones which oppose the action of insulin are increased glucagon and increased epinephrine. The activity of these hormones is increased in the absence of insulin. So these are diabetogenic agents, hormones, and in the liver, this leads to increased gluconeogenesis, increased glycogenolysis. So glycogen is broken down and proteins are converted into glucose. This contributes to hyperglycemia. Similarly, muscle, because in the absence of insulin, the uptake and metabolism of glucose in the muscle is impaired. So there is decreased uptake of glucose by the muscles, and this also contributes to hyperglycemia. Hyperglycemia leads to osmotic diuresis. Osmotic diuresis is associated with electrolyte imbalance or electrolyte depletion. This leads to dehydration. So dehydration may also lead to coma and death. On the other hand, in the absence of glucose as a nutrient, energy source, in the absence of glucose as energy source, the energy is derived from breakdown of fats and proteins. So breakdown of fats from the adipose tissue due to increased action of lipoprotein lipase, the neutral fats in the adipose tissue are degraded. Lipolysis leads to increased fatty acids. Neutral fats are combination of glycerol and fatty acids. So there is increased free fatty acids in the circulation, and in the liver, these increased free fatty acids are metabolized. That is beta oxidation of fatty acids. So this is the important source of energy in diabetics. So when the absence of adequate utilization of glucose, these fatty acids become the source of energy, and in the absence, if the fatty acid oxidation is excessive, that means beyond the capacity of the peripheral tissues to utilize the energy, then fatty acids are converted into ketone bodies in the liver. So there is imbalance between the energy production and utilization. When the production increases, that is fatty acids are increased, when increased beta oxidation of abundant fatty acids will lead to formation of ketone bodies, ketone in the liver. Ketone bodies are acetone, acetoacetic acid, and beta hydroxybutyric acid. Beta hydroxybutyric acid. So these ketone bodies are levels are increased in the blood, that is called ketonemia, and these ketone bodies are excreted in the urine, that is called ketonuria, ketonemia and ketonuria. And these ketone bodies, keto acids, this will cause metabolic acidosis, and this will cause ketoacidotic coma and death. This is the pathogenesis of diabetic ketoacidosis. And there are other important systemic complications like diabetic vasculopathy and other things. Diabetic vasculopathy is involvement of the blood vessels. Both large vessels and small vessels are affected. The condition the changes which are seen in the medium-sized muscular arteries and large vessels like aorta, that is described as macroangiopathy. Macroangiopathy affects large vessels like aorta and medium-sized muscular vessels. Medium-sized muscular vessels supply heart, cerebral vessels, and also the limbs. So important disease that is associated with the late complications of diabetes is atherosclerosis. Premature early onset of severe atherosclerosis may lead to myocardial infarction because of coronary artery atherosclerosis and thrombosis that leads to myocardial infarction, or in the brain it may lead to cerebrovascular accidents, cerebrovascular disease, which may manifest as cerebral thrombosis or cerebral hemorrhage, which may also lead to coma. And in the peripheral circulation, the circulation in the arteries supplying the limbs, lower limbs, if the atherosclerosis affects popliteal vessels, then patient may develop gangrene, dry gangrene. So these are the macrovascular complications due to atherosclerosis, premature and severe atherosclerosis. And vascular changes also occur in the small vessels, arterioles and capillaries. This is described under the term microangiopathy. Micro means small, angio means blood vessels. Small blood vessels are the arterioles and capillaries. So these vessels show basement membrane thickening. So this is known as hyaline arteriolosclerosis. Hyaline arteriolosclerosis. And the renal complications are very important. Diabetes is important cause of end stage renal failure, chronic renal failure, end stage renal disease due to chronic renal failure. This is commonest cause of death in diabetes, and there are 4 types of lesions which are already described in connection with kidney diseases under the term diabetic nephropathy. Just a recollection of the involvement of kidney in diabetes. There are 4 or 5 types of changes that are described, particularly in the glomeruli. In the glomeruli, the disease is described as a diabetic glomerulosclerosis or glomerulopathy, which includes diffuse and nodular lesions of glomerulosclerosis, diffuse basement membrane thickening, mesangial sclerosis, and nodular lesions in the mesangium. That is known as Kimmel-Stein-Wilson's disease. So this is very important. This may lead to renal failure, chronic glomerulosclerosis, and the blood vessels, afferent arterioles and afferent arterioles become thickened, hyalinized, and the lumen is occluded. So this is called hyaline arteriolosclerosis. That means involving small vessels which supply the glomeruli, afferent arterioles and afferent arterioles. Even the big vessel that supplies the kidney, that is renal artery, also may be affected by macroangiopathy, that is atherosclerosis of the renal vessels lead to renal ischemia. And the infective complications are there. In diabetic patients are prone to infections, urinary tract infections, and ascending infection may lead to diabetic pyelonephritis. And the most important complication of pyelonephritis, acute pyelonephritis, is necrotizing renal papillitis or papillary necrosis. And if it is bilateral, this may lead to acute renal failure. And the tubular lesions, continued uncontrolled diabetes associated with hyperglycemia and glycosuria. This glucose is taken up by the proximal convoluted tubules, and the tubular lesions develop. They are described as Armani-Epstein lesion. Vacuolation of the glycogen, vacuolation of the proximal convoluted tubular epithelial cells. And that is about diabetic nephropathy. Diabetic neuropathy affects both central nervous system and peripheral nervous system, and the pathological changes are in the form of segmental demyelination, Schwann cell injury, and axonal damage. The presentation may be in the form of polyneuropathy, classically described as blow and stalking sensory impairment, mononeuropathy, carpal tunnel syndrome, wrist drop, foot drop, and autonomic neuropathy. The symptoms include postural hypotension, nausea, vomiting, impotence, and gustatory sweating. And late complications. So, diabetic retinopathy. This is very important complication of diabetes mellitus. Uncontrolled diabetes mellitus may lead to ocular changes, leading to adult onset type of diabetes, blindness. It may lead to blindness. So these complications can be divided into proliferative, those affecting the retina and those affecting the other parts of the eyeball. So retinal retinopathy may be non-proliferative retinopathy or proliferative retinopathy. Non-proliferative retinopathy, the small abnormalities in the retina, small vessel abnormalities in the retina leading to exudates, hemorrhages, and microaneurysms. And these changes will not affect the visual acuity. But whereas in case of proliferative retinopathy, it is a serious condition in which there is proliferation of new capillary vessels in the retina, and these capillary vessels may rupture, leading to vitreous hemorrhage, and this may be associated with the loss of vision. Vitreous hemorrhage so leads to blindness of the eye. So another maculopathy. Maculopathy is caused by edema, hard exudates, and retinal ischemia, and results in marked reduction of the acuity of the vision. And apart from this, there are other important complications in the eye. There are premature cataract and glaucoma. And the infective complications. Diabetic people are susceptible to a number of infections, including tuberculosis, pneumonia, pyelonephritis, as I have discussed in the kidney, by infection of the renal pelvis and kidney, pyelonephritis, otitis media, otitis externa or media, and carbuncles, skin infections, carbuncles, boils and carbuncles, and diabetes ulcers may develop, and this may have several underlying pathological conditions. So this could be the way the increased susceptibility to infection is due to various causes. It is due to impaired leukocyte function. The phagocytosis and is impaired in the case of diabetes. Neutrophil phagocytosis is impaired, and there is reduced cellular immunity. This leads to development of granulomatous infections such as tuberculosis, and poor blood supply due to ischemia, vasculopathy, atherosclerosis of the vessels, or due to hyaline arteriolosclerosis. It may lead to tissue ischemia. Tissue ischemia makes the tissue susceptible to infections. So ulcers on the foot will not heal properly because of vasculopathy and neuropathy. The delayed healing of the ulcers, diabetic ulcers, and also gangrene are due to vasculopathy, and the hyperglycemia itself contributes to infections, predisposition to infections, because the glucose that is present abundantly in the blood is not utilized by the bodily tissues, but this is a good nutrient for fermentation by the bacteria. So the bacteria flourish well in the presence of high glucose in the interstitial tissues and blood. So this glucose is utilized by favorably by the bacteria. So bacteria flourish in the environment provided by the good nutrient glucose. So that's another cause for the predisposition to infections in diabetes mellitus. So the same thing is illustrated here. How hyperglycemia directly or indirectly contributes to various complications. Atherosclerosis, diabetes, nephropathy, neuropathy, retinopathy, like that. So most important pathogenetic mechanism is non-enzymatic glycosylation of proteins. This is very important. The proteins are non-enzymatically glycosylated. The glucose and the metabolites of glucose combine with amino acid residues of proteins. Initially, the combination, the complex formation is reversible, but lately there is irreversible complex formation with proteins. So the glucose irreversibly forms a complex with proteins, and that is called advanced glycation and products. Advanced glycation and products. And we have seen in the investigations the hemoglobin, the globin, the protein part of the hemoglobin is irreversibly combined with glucose, that is hemoglobin A1C. So that persists as long as the red cell survives. That persists as long as the red cell survives. Red cell survives for 120 days. So it gives an idea of glucose maintenance in the last 120 days. So that is the importance of using this test, hemoglobin A1C, in the management of diabetes mellitus. So it assesses the long-term management of the diabetes. So this same type of advanced glycation end products also form in various tissues, including the blood vessels, by combination of are making cross-linking with collagen type A. Atherosclerosis, decreased elasticity and atherosclerosis develops. Cross-linking with the type 4 collagen that is present in the basement membranes, and the mesangium is the basis for diabetic nephropathy. And the same glycosylation and products which are not readily degraded, and there is no turnover, so they are permanently causing changes in the function, structure and functions of the extracellular matrix. So that is the basis for a number of complications and increased vascular permeability to the protein, like causes diabetic neuropathy, retinopathy and other things. So in the there is neovascularization. This by proteins kinase C activation, the hyperglycemia causes endothelial proliferation. That is called neovascularization. New blood vessel formation in the retina will lead to diabetic retinopathy. So, and another thing is some tissues like lens, nerves, and some blood vessels and kidneys, they do not require insulin for uptake of glucose. Glucose directly enters into the tissues, into the lens or other tissues, nerves and other some tissues, without requirement for the insulin. So directly hyperglycemia, the high glucose enters into the tissues. So in the lens, for example, the glucose is converted into sorbitol by aldose reductase enzyme. So the sorbitol is further converted into fructose, and these are metabolites which draw excess of water into the cells, and this osmotic damage occurs into the lens, in the lens, and also retinal pericytes in the lens. It will produce a cataract, premature cataract. So in the Schwann cells, this kind of polyol mechanism, that is called polyols, sorbitol accumulation leading to osmotic changes, will lead to Schwann cell injury, causing demyelination, and that is the basis for diabetic neuropathy. So these are the various complications